In this initial introductory lecture to trauma, we're going to cover the ABCs and shock. The thing about emergency medicine is the ability to respond in the moment, in a second, to make those split-second decisions without having a lot of information. As you approach this stuff for the first time, it'll be awkward as you deal with questions because you have to put yourself in the moment in which you arrive on scene to find the guy in a pool of blood, or in that moment when the ambulance rolls into the trauma bay. You don't have access to all the tools and diagnostic steps. You have to act. So let's start off by talking about the ABCs and then going into shock. So whenever you do an initial assessment on someone, what you want to look at is the airway, breathing, and circulation. The first thing you have to decide is, can the person maintain a patent airway? That is there a rigid tube between the air and their lungs? Normally the answer is yes. The trachea has fibrous rings, maintains a sturdy open portal for air to get in and out. But in the setting of trauma in particular, the airway may not be patent. So you can look at someone and say, this airway is patent if they speak full sentences without pausing. There's no accessory muscle use, and there are bilateral breath sounds. When you come up to somebody and you see certain things, you might think, this person's airway is not gone yet, but it could get there. You might be able to identify an urgent airway by seeing an expanding hematoma. By hearing or feeling cutaneous emphysema, that is Rice Krispies, in the skin, or in someone with inhalation burns. What you're doing is you're saying, okay, there's something wrong with the airway, the lungs themselves, or the vascular system, which could eventually lead to a compromise. They're not compromised yet, but they could be, so these patients may still need to be intubated. And then someone who needs an emergent airway is someone who's apneic. Of course, if they're not breathing, you'll have to breathe for them. What you should look for in trauma is the GCS level. And remember the limerick, GCS less than 8, intubate. But someone who's had gurgling or gasping needs to have their airway secured because they basically have done something else is in the way. And anytime you hear stridor, inspiratory wheeze, it means that the entrance to the entire tracheal system is compromised and you need to secure the airway before it closes. Breathing, you might think of in a very similar way to airway, right? If someone has a patent airway, they're probably breathing fine. But someone may have an intact airway, but they just aren't breathing, or they're not oxygenating well enough. So what you're looking for here in the breathing category is both ventilation and oxygenation. And I don't want to get too deep into this because during the initial assessment is, are they breathing? Is their oxygen fine? But when you think about it, ventilation and oxygenation are two very different things. Ventilation is carbon dioxide. Oxygenation is oxygen. You manage ventilation by changing the minute volume. That is by adjusting the tidal volume and the respiratory rate. Oxygenation is managed with PEEP and FiO2, that is the surrounding oxygen in the air around you. In fact, as you begin learning about ventilators later, what you'll realize is these are the things you set. You measure CO2 by getting a blood gas. You can measure oxygen by getting a blood gas, but often the pulse oximeter is just as good. So someone who is adequately moving air during initial assessment and someone who's got a decent reading on a pulse oximeter counts as having good B breathing. If you want to get more advanced, you can start looking into these things. And as a caveat, a pitfall you might fall into, end-tidal capnography, end-tidal CO2, you're looking for a number of 40. The end tidal does not measure the amount of carbon dioxide in the blood. What it does is measure endotracheal placement. If the end tidal CO2 is 40, your tube's in the right place. Don't be confused by the end tidal CO2 as a means of measuring CO2 in the blood. This is only for placement of the endotracheal tube. And in circulation, let's see. What we're talking about here is identifying someone who's in shock. And we've got more advanced lectures here in Online Med Ed in the intern lecture content. Oxygen delivery, shock 1, shock 2, shock 3. This topic is really big. So as you study for your shelf, use this. But recognize the truth behind these topics are much more intense than we're giving you in this video. So when you think of circulation, you need to identify someone who's in shock. Again, this is initial assessment. The AHA defines hypotension as a systolic blood pressure less than 90. The thing that actually matters, as we'll talk about, is the mean arterial pressure, and that's less than 65. We know that this is bogus because some people happen to have low blood pressures, but when you see a blood pressure less than 90, antenna should go up and say, oh, this person might be in trouble. And another objective measurement we use is the urinary output. And urinary output less than 0.5 cc's per kilo per hour is indicative of oliguria, insufficient renal perfusion. Of course, this is presumed to be in someone who had good kidneys, which is why we use it primarily in the traumatic setting. And then just from the clinical picture, someone who's pale, cool, and diaphoretic. Pale, cool, and diaphoretic with a sense of impending doom, who would otherwise be healthy in the setting of trauma, is a bad sign. Before we get to talking about circulation, which is the mean arterial pressure, let's talk about some airway and breathing stuff. The first thing you might do to intervene is simply give someone some oxygen. And there's a couple of ways to do that. And we talk about oxygen delivery methods in that intern video. Nasal cannula, face tent, non-rebreather. But in the way of trauma, if someone comes in sick, you're just going to throw a bunch of oxygen on them. If they're not breathing by themselves well enough, you might assist with a bag valve mask. You put in an oropharyngeal airway to keep the airway more patent, and then you just bag them. Bagging can give way to the endotracheal tube, where you put a tube in through the mouth, down the trachea, and now it's really rigid, and you have maintained patency, and you take over control of ventilation and oxygenation. In the traumatic setting, though, especially when it comes to facial trauma, you may not be able to use the endotracheal tube. For whatever reason, their mouth is full of blood, they've got a messed up face, you can't put the laryngoscope in appropriately. Whatever the case may be, you might need to crike somebody. With a crike, you find a little space underneath their thyroid, you throw in a blade, and you put a Twizzler in. It's a tiny little straw that they breathe through. It's better than nothing. And a crike can be done emergently at the bedside in the ER. Now, I'm sure you've seen patients who have trachs. Crike and trach are different. Trachs, tracheostomies, are put in the OR under very controlled conditions, non-emergent. So in the emergent setting, crike somebody with facial trauma you can't intubate, then later exchange it over to do a tracheostomy, long-term care. Bring it back to circulation. Circulation is the back half of this lecture. It's all about the mean arterial pressure. And the mean arterial pressure equals the cardiac output times the systemic vascular resistance, such that when there's a problem with vascular resistance, the cardiac output will compensate. And what I want you to feel is systemic vascular resistance is the tone, right? The blood vessels, how tight they are. And I want you to feel it's a lot easier to fill a tube that big than it is a tube that big. The cardiac output's a little bit harder to understand conceptually in that metaphor because it's actually made up of three different parts. The cardiac output is a combination of the heart rate and the stroke volume. And stroke volume is a product of preload times contractility. If any one breaks, since these are all multiplied together, if any one breaks, the others will try to compensate to maintain the blood pressure. you get circulatory compromise when more than one breaks, or one breaks so severely that the others can't compensate. My approach to shock, as you'll see in shock 1 in the intern content, anytime I see someone with a low blood pressure, I go around the circle. First is heart rate. You're either too fast or you're too slow. If you're too fast, you're so far to the right in the Frank-Starling curve that you don't have any type of diastolic filling whatsoever. And even though the heart rate's high enough, you effectively eliminate preload. You need time to fill the heart. So if the heart rate is too fast, then you can't fill. If it's too slow, there's plenty of diastole, you're filling the heart just fine, you just don't beat enough times per minute to maintain the blood pressure. When it comes to preload, there's two things. The first is being volume down. And in the setting of trauma, that means hemorrhage. But you might also have obstruction. And obstruction comes in the way of 3 diseases, 2 of which we'll talk about here. Attention pneumo and pericardial tamponade. The third one is pulmonary embolism. Tension pneumo and pericardial tamponade obstruct blood flow to the right ventricle. Pulmonary embolism obstructs blood flow into the left ventricle. When it comes to contractility, what we normally think of is congestive heart failure and myocardial infarction. But in the traumatic setting, and we'll talk more about this one in particular in the chest trauma lecture, a myocardial contusion looks just like a CHF exacerbation, only in the setting of a healthy heart and a trauma. Now you notice this dashed line. That dashed line was put there on purpose. It's because systemic vascular resistance is very different than cardiac output. All of these comprise cardiac output. Systemic vascular resistance can be a product of a couple of things. And we'll finish with this at the very end. Sepsis, anaphylaxis, anesthesia gone wrong, or spinal trauma. And in all cases, the problem is vasodilation that's inappropriate. All right, so let's go over the actual diseases you need to know about from this topic. The first is hemorrhage. The patient is losing blood. Now, if they've been shot or they have a GI bleed and there's blood everywhere, you're not going to have trouble spotting that. Even if there's a closed femur fracture, one leg is going to be 3 times the size of the other, you're not going to miss that. But where you'll miss it is intraperitoneal hemorrhage, which can hold a ton of blood. In the way of identifying a vignette, hemorrhage is going to cause loss of your blood volume, so your neck veins are going to be flat. And because your heart and lungs are fine, you're going to have normal heart and normal lungs. And you might find the deformity or the hole that's bleeding. Be careful, because you might think that hemorrhage will have a decreased hemoglobin. And you're right, but what's stronger is that because you're losing preload, heart rate and contractility will go up, so your heart rate will increase. And I say you need to be careful with the hemoglobin, because hemoglobin is a concentration. If you're losing blood acutely, you lose both plasma and blood. It's not until you had fluid shifts or you give intravenous fluids that you reveal the true anemia. In the acute setting, the hemoglobin does not change. If the hemoglobin has changed, it means that there's a significant impact. And what you're going to do in the way of the initial assessment when you're in the trauma bay is do a FAST. This is an ultrasound. What you're looking for is blood. If you identified hemorrhage, you want to plug the hole, so you apply pressure. And then you go to the operating room, because they need to have surgical closure to whatever's bleeding. On your way to the OR, what I want you to feel is, for hemorrhage, you don't stick in the trauma bay resuscitating someone. You take them to the OR to get fixed. And on the way, you put in the large bore IVs. Type and cross, give fluid, give blood. You don't let them sit in the ER getting blood and fluid waiting for the OR to be ready. You go to the OR. All right, that's going to be very different from the tension pneumo and the pericardial tamponade, both in the way of patient presentation and what you're going to do about it. For tension pneumo, what happens is that you've got a really bad pneumothorax. Think of it as a super pneumo. The peritoneal space between the chest wall and the lung gets filled with air. For whatever reason, it continues to fill with air, and then what makes it tension, not just a pneumothorax, is that it crushes the IVC. If you have a crushed IVC, no blood flow can return to the right heart. In that case, you'd have shock, so you'll have hypotension. If you compress the IVC, blood is going to back up in the veins. So you'll have engorged neck veins, JVD. And because the heart isn't the problem, you'll have a normal heart. What you're going to get is a bunch of air where the lung should be. And so you'll have decreased breath sounds and hyperresonance. And the thing that helps you identify the tension pneumo is the tracheal deviation. You'll say, okay, I got this guy here in the trauma bay. I know what I'll do. I'm going to go ahead and get a chest x-ray since there could be a problem with the lung. No. If you've identified someone with a tension pneumo and you found the area of the pneumo with the hyperresonance and the decreased lung sounds, there's only one step. That's needle decompression. And this is not a chest tube. A thoracostomy is the definitive treatment for a pneumothorax. A tension pneumo needs a 14-gauge needle over the top of the second rib. You just dart them. What you're doing is trying to not undo the pneumo. You're trying to undo the pressure on the IVC. Once you relieve it, then you get the chest x-ray and do the chest tube. Same thing for pericardial tamponade. This is when you have blood around your pericardium. The left heart is big and thick. The ventricle is really strong and so can withstand lots of pressures. Right heart, weak and floppy. So if there's a rapid accumulation of fluid, it compresses the right heart, again, not permitting any blood in. So a pericardial tamponade is a suprapericardial effusion. And because blood can't get into the heart, you're going to have engorged neck veins. And now the differences between tension pneumo and pericardial tamponade, you're going to have normal lung sounds. Because the lungs aren't the problem. But you're going to have distant heart sounds. And hypotension. Here I'm writing hypotension on the board because the presence of JVD, distant heart sounds, and hypotension is Beck's triad. That tells you there's pericardial tamponade. And pericardial tamponade is a clinical diagnosis made by pulsus paradoxus greater than 10. A lot of people like to get the echocardiogram, and you can check to see that where it is using the FAST. The FAST is an ultrasound, so it's effectively your echo. But you should not order an echocardiogram when you have pericardial tamponade. You should be doing a pericardiocentesis. You put a needle in and drain the fluid. Now, it's actually the standard of care to do it under ultrasound guidance. But feel the difference between the ER resident with their ultrasound machine finding where the fluid is and sticking a needle in it versus ordering the echo tech to come down from the 5th floor after he's done with his current echo in order to show it to a cardiologist to send him to the operating room to put a needle in it. That latter condition is not for pericardial tamponade. The first one, where you just have an ultrasound and stick a needle in, that's what you want to do. Just so we talk about it, I want to tell you about the problems with contractility. If someone has an issue with contractility leading to shock, it's probably not going to be in the traumatic section. But because it's heart failure, you're probably going to have engorged neck veins. But even though you have engorged neck veins, the lung sounds are going to be full of crackles as well. And in the setting of systemic vascular resistance, if you have a problem with SVR, you have vasodilation. And the thing here is you have warm extremities, despite hypotension. That's why this dashed line is here, to remind you that everything to the right is going to be hypotension and warm. Everything to the left is going to be hypotension and cold. The reason is if one of these things in cardiac output breaks, systemic vascular resistance goes up, vasoconstriction, cutting off blood supply to the distal extremities. If the problem is systemic vascular resistance, vasodilation, everything opens up and you get warm perfusion. The things I really want you to take away from this are going to be identify the person who needs emergent intubation, knowing that you have to crike somebody if you can't tube them because of facial trauma. Save the trach for the OR later. In the way of intervening immediately, if someone has hemorrhage, yes, you're going to put IV lines, give fluid and blood, but the only thing to do is get them to the operating room so they stop bleeding. If you've got a tension pneumo, you do a needle decompression. Tension pneumo, hypotension, engorged veins, decreased breath sounds, hyperresonance, and tracheal deviation away from the site of the injury. Pericardial tamponade, you make that diagnosis, you do a pericardiocentesis. There is no diagnostic step. Pericardial tamponade, engorged neck veins, hypotension, normal lungs, but distant heart sounds. Put a needle in it. Be careful about contractility. We'll talk more about that in the chest trauma lecture. And for vasodilatation shock, anything involving SVR, you're going to have warm extremities, and that's where you pick vasopressors. Overview topic only. Every segment in this lecture has its own lecture in the intern content. So if you're really interested in knowing more, check those out. Set them just for the shelf. Know these three things and a little bit about the ABCs. And that is the initial approach to trauma.